Balloon atrial septostomy is the classic bailout procedure for the deeply cyanosed and acidotic newborn with d-transposition of great arteries and poor admixture. Since the systemic and pulmonary circulations are in parallel in d-TGA, it is urgent to provide good mixing at the atrial level, which is the most preferred site at the earliest. This is where the balloon atrial septostomy comes in as a life-saving option which buys time for corrective surgery. Balloon atrial septostomy was initially described in 1966 by Rashkin and Miller. In the immediate neonatal period, the approach is often through the umbilical vein, though femoral vein is an option later on. Balloon septostomy catheter is introduced into the left atrium under fluoroscopy or sometimes under echocardiographic guidance. Echocardiography is more often used to guide the proper position of the intraatrial septum rather than as a total guidance in the absence of fluoroscopy. The balloon at the tip of the catheter is inflated and abruptly pulled back into the right atrium, tearing the interatrial septum. A good defect will improve the mixing and consequently the systemic oxygen saturation as more deoxygenated blood reaches the lung for oxygenation, unlike the pure d-TGA, in which hardly any portion of the systemic venous drainage is carried to the lungs for oxygenation. Adequacy of the septal tear is indicated by only minimal gradient across the interatrial septum after the procedure. Beyond the neonatal period, septum becomes thick and difficult to tear by simple balloon atrial septostomy, when a blade atrial septostomy may be needed. This procedure utilizes a catheter-mounted blade to make an incision in the interatrial septum. Balloon atrial septostomy can also be used as an initial palliation in other conditions which require good mixing at atrial level, as in total anomalous pulmonary venous connection.